Good evening and welcome to Doctors on Call. I'm Dr. Mary Owen, faculty member at the University of Minnesota Medical School Duluth campus and family medicine physician for the Center for American Indian Resources, Fond du Lac Band of Lake Superior, Chippewa. I'm your host for our program tonight on heart problems, heart failure, anemias, and bleeding problems. We'd be happy to take your questions on the diagnosis and treatment of heart problems, high blood pressure, bleeding disorders, or any other cardiology questions you might have. Success of this program depends on you, our viewers. Please call or email your questions and we'll do our best to address them. The telephone numbers for your questions can be found at the bottom of your screen. Our panelists this evening are Dr. Mark Erhard, a cardiologist with St. Luke's Cardiology Associates, and Dr. Victoria Heren, a family physician with Community Memorial Health Raiter Family Clinic in Cloquet. Members of the WDSC staff are standing by to take your phone calls. And now on to tonight's program. Good evening to both of you.
Good evening.
Thank you.
So I have lots of questions, particularly, of course, around the impact on cardiology from the COVID, from the pandemic. And I'd like to know from you, Dr. Erhard, are you seeing some sequelae of people not having gone in for their regular care during the pandemic?
Yes, it has been tough. There's been a lot of fear of going to a physician's office or associating in a location that you could potentially pick up the disease. I think some of it is unwarranted, that fear, and I think that fear should definitely be, as more and more people get vaccinated, I think it'll be much easier and there'll be much less fear. But I do believe there's also been some procrastination of follow-up and of continuity of care, and some people fall through the cracks and they're kind of afraid, well, I haven't been in for a long time, now what do I do? Mm-hmm. And I think that's been a complication of the fact that we have had this aversion to doing things in public and to going in and being in a personal contact with another individual. And I think fortunately that's coming to a close. And I think that we hopefully can be able to restore those relationships and that preventive health, which is so critical for the community and very critical for people that especially have advanced disease.
Dr. Heren, you and I were just talking before the show about one of the changes we saw with COVID was change to more virtual visits. Has that slowed, or do you see any problems with that with cardiovascular disease or any other diseases?
Virtual visits work fine for some things, especially mental health and follow-ups, but when it comes to a lot of things, including cardiovascular disease, being actually able to listen to somebody's lungs, listen to their heart, feel their pulse is very, very important. Listen to somebody's breathing, see how their exercise tolerance is. Meeting face-to-face can be very important. And getting over the fear of coming to the clinic, we're following the guidelines, safety precautions. More and more people are vaccinated. It really can enhance somebody's health care and keep them out of trouble, out of the hospital, and from having to go see the cardiologist for a heart cath or worse, if they'd come in and actually get checked out properly.
Thank you. Thank you. Now, enough of the COVID questions. On to other questions. I hear from my patients all the time, what do they do if they have a strong family history? I'll start back with you, Dr. Heren. Strong family history of heart disease or cholesterol problems. Does that mean that they are destined to have the same?
Fortunately, that's not true. But I think it's important to look at what's your own individual risk factors. You can't change your family. I'd love to be able to, one of my first common questions is, pick your parents well. Did you pick your parents well? Well, if your parents do have advanced disease at an early age, you need to do something different. So it's nice to look at were your parents smokers? Were there diabetics that weren't under control? Did they exercise? Did they get plenty of sleep, which is critically important for long-term survival, especially as we age? Sleep is very, very important and often underplayed. Those are the questions I ask. But if you have a deck that's stacked against you, you have to do something different than the previous generations. And we know many things you can do. One of them is eating right, and exercising and being outside are so critically important for cardiovascular health.
Is there any need for some people with that strong family history? I've seen some people talk about starting statins as early as 20 years old when people have.
We have guidelines on this now. We now have some testing that can be done if you do have an early family history of coronary disease. And finally, after nearly 30 years of experience, the American Heart and the American College have weighed in of doing coronary artery calcium scores. If you have a strong family history of coronary disease and you're 40 or 45 years old and someone says, well, you just got to start this statin right away, we have guidelines. And as of 2018, those guidelines have been pretty much solidified, which means if you have no coronary artery calcium and you're not a diabetic, you need to continue to do lifestyle changes, but you don't need to start a statin. The statin therapy can be put off on those patients unless they're diabetic and can make a tremendous difference.
One last question on this same topic. Are those tests hard to get? If you're out in a rural area, can't get in.
They are getting easier to get.
Okay.
They're in the state of Minnesota at most major locations. They're between $100 and $200 maximum. And I don't recommend them getting more than every 5 years apart. But it'll tell you exactly how, if you're 55 years old and you have some coronary calcium, it'll tell you, are you the middle percentage or are you the bottom percentage? I get one on myself every 5 years, so do all my family members.
And you don't have stock in this company?
I have no stock in the company. This is name one thing in medicine that was $395 nearly 30 years ago and now is down to less than a half or a third of that price.
Okay,
so it's a wonderful, it also can pick up other things too as a bonus. Aneurysms, cancers. I've had a lot of people. I have been a very strong advocate for the last 7 or 8 years on using this to decide who to start on statins and who can defer that decision.
Okay, good to know. Thank you. Dr. Heren, your turn. We talked a little bit about the fact that there's a misconception that women don't have heart disease as often or don't have the same kind of outcomes as men do. Tell me more about how women differ than men, or if they do with heart disease.
Well, women do get their heart disease. They tend to get it later than men. Childbearing and estrogen seems to be protective earlier, but then menopause comes along and women start catching up. So they get their heart disease. They get it just as much as men. They just tend to get it later. And they don't tend to have the classic signs that men do. A lot of the things that a lot of people think about in terms of the elephant sitting on your chest or the pain going down your left arm were standardized from men. Women can get anything from neck pain, jaw pain, very bad indigestion, just feeling short of breath or very weak. It can be a lot of things that women may just write off as, oh, I'm just not feeling well, unless they're thinking, you know, that could be my heart. I should maybe get this checked out. I'm just not feeling well. I've known people to sit home with horrible indigestion, only to find out that when they went in, they sat home with their heart attack.
Are there some diseases where you might not have the same kind of, even those symptoms?
You can have a totally silent heart attack.
Okay, thank you. Is there anything that puts you at more likely to have a silent heart attack than other diseases, or just you can't determine that?
Well, diabetics very often will have more silent heart attacks. They have more chance of having some nerve damage, so they just don't feel things the way they maybe ought to. Their body just doesn't tell them that.
Okay, thank you. Dr. Erhard, back to you. You'll get back to your turn here in a second, Dr. Heren. This gentleman caller had a defibrillator put in 2005. Have there been any improvements since then?
Significant improvements. There's one of the things that used to limit defibrillator usage in the past is the batteries just didn't last very long. So the batteries, many times people that had the early defibrillators were getting new defibrillators, new generators. You don't change the battery, you change the whole generator. So you get the new technology when that updates. But the batteries have improved significantly, and the detection ability of these devices for going off inappropriately is so rare. So I think that the technologies of these major companies have improved because there are so many people that benefit from these technologies. I've had many people, and it's really good to find people that have had, 16 years ago I had a defibrillator and I'm still alive.
Yeah.
Before that, before that, many years ago, we had no technologies for those. So this is one of the advances of and the fortunate things of living in this age.
Dr. Heren, is a heart rate over 100 a concern, and what does it mean?
Got to take everything in context. If you're running up the stairs, heart rate of 100 is perfectly normal. If you just watched a really scary TV show, it's fine. There are a lot of instances where a fast heart rate is perfectly normal. If you're sitting relaxing, your heart rate is normally supposed to be under 100. Now, if it's 101, 102, probably not going to quibble about that. If it's significantly higher than that, you got to wonder. The normals are quoted as 60 to 100. It is kind of a bell-shaped curve, so some people run higher, some people run lower. If you're running consistently over 100, you might want to get it checked out, because there are a number of things that can cause a high heart rate that are actually significant problems, and running a fast heart rate long-term can be bad for your heart.
Are there, how about exercise? Does that change your heart rate? Long-term, say for Lance Armstrong or someone else is maybe
Really
not the
good
best idea,
really
but.
good athletes run really low heart rates.
Okay.
They
And
get
that's
very
okay.
strong muscles, their heart is very efficient, and they just don't have to beat as much.
And their blood pressure, does that change too?
And their blood pressure runs low, and that's very good for them.
Okay. We talked before the show a little bit about HDL and LDL and what those mean for people. And most people are aware now that really high LDL, not so good, a higher HDL, pretty good, the high density. Can you talk a little bit about that? And are there exceptions to those rules?
Well, talking about the breakdown of the cholesterol, it's always a good idea to get the breakdown, because just the total doesn't tell you the whole story by any means. Your LDL, or low density cholesterol, can even be broken down further, but that's kind of high tech and we don't usually do it, is normally considered your bad cholesterol. And the higher that is, the worse it is. And that's normally the target, because we have a number of drugs that can control that. Your HDL, or your high density, is normally considered your good cholesterol, because that's normally what takes the cholesterol out of your veins and brings it back to the liver, kind of cleaning up. So you want that kind of high. There are instances where a high, really high HDL can be indicative of a high density lipoprotein that is just not working correctly. So sometimes the number can be really high and it's just not working. So there can be instances where just having oh, my HDL is 100 really doesn't mean that it's a good thing.
Thank you. Dr. Erhard, anything to add to that?
Yeah, I think in general we've looked for males to have HDLs higher than 40, and for females to have HDLs higher than 50, especially the premenopausal male. And I agree that magic formula of estrogen is cardioprotective for most women up until when menopause takes place. And then all of a sudden you lose your advantage. And that advantage that helped your bones and also helped your coronary disease goes down, and you start catching up with us, and we're not diagnosed very well either. So I would agree. Specifically, the women are truly from Venus and we are from Mars. And heart disease is definitely different between the two and the discovery thereof. But it's still the number one killer of both sexes. So this clearly, good HDL cholesterols are usually cardioprotective, usually are, but not across the board, and I agree. However, you can raise your HDL by exercising. Exercise can raise the HDL 20%. Eating right, avoiding highly processed foods, and eating, in general, the more man touches it, the more we mess it up. We want foods closer to the natural state that have not been distorted and have not been processed to a degree. We take a lot of the nutrition out in processing. So that's what we really want to go to, is raising your HDL with exercise, stopping smoking, eating right, sleeping right. Those are the things that we can. But to some degree, people are born with an HDL that can be a real bad and a very low problem. We do see those people out there.
You know, we talked a little bit about before the show as well. We talked a lot before the show. We talked a little bit about those medications that we commonly call statins now. And I have had patients who, for whatever reason, they can't take statins. They react poorly to them. And you told us a little bit about some newer medications. Can you tell us about that right now?
Yeah, the mainstay for many years, for about 40 years, has been statin therapies, and they've been studied more than any drug in the history of the pharmaceutical industry. They're mostly all now generic, they're very inexpensive, but there are clearly some people that don't tolerate, or you may not tolerate your type of statin. There are statins that dissolve in fat and statins that dissolve in water, and sometimes the statins that dissolve in fat may have a reaction. Those that dissolve in water, people tolerate very well. However, there are some new drugs that you may see advertised. They're specifically for a small percentage of patients, either those patients with have advanced coronary disease that can't tolerate any statins, and those are called the PCSK9 inhibitors. So far, there are only injectable forms, and primarily they're marketed to those that cannot tolerate with advanced disease, or they're born with a certain genetic predisposition called familial hypercholesterolemia. And those people often have LDL cholesterols 2 to 3, 4 times what is normal. And those are what those drugs were developed for. But we've now used them in patients that can't tolerate statins that clearly need a statin.
Okay.
So there have been good therapies that are coming that are newer.
Okay, thank you. Dr. Heren, there are a lot of questions out there about how the heart's working. So someone has a question. They have occasional skipped beat. They're 75 years old. How serious is that?
Pretty much everybody has skipped beats. Some people feel them and some people don't. I can only feel mine if I take my pulse, and especially after exercise. Other people can feel them just sitting there. An occasional skipped beat is absolutely nothing serious if it's an occasional skipped beat. Nothing to worry about at all. If it gets to the point where your pulse is very irregular, not just skipping a beat now and then and regular in between, if you have just a very irregular pulse, that could be a serious arrhythmia and you should get it checked out.
Good. Anything different to add?
I agree. I think that physicians 30 years ago looked at premature beats in a different way. Now, after a major study was changed called the Cardiac Arrhythmia Suppression trial, we don't treat those premature beats like we used to. In general, they have nothing to do with lifestyle. They do not need to be treated unless they are interfering with your activity or they affect your dizziness or your hemodynamic component. That may be a different situation, but those are rare.
Thank you. Dr. Heren, I have a patient who has atrial fibrillation and has not been able to get it under control despite different interventions, including cardiac
Ablation.
Thank you, ablation.
Oh, talk to Dr. Erhard.
Dr. Erhard, what are their options?
Atrial fibrillation is a disease of advancing age. 96% of atrial fibrillation occurs after age 60. It's a disease as we get older. Both of my parents had that before they died. And the big concern with atrial fibrillation is stroke risk. That's the concern. Our blood is designed to move, and when God only knows why he put it there, but in the top of the heart there's a little appendage that tends to harbor clots, and that appendage is the clot that killed my mother. Okay? So there's no question that that is something that we worry about. But ablations have gotten better, significantly better over the years, but there are still some people that don't respond. And when they become completely disabling, you can have what they call an AV node ablation and a pacemaker. And then the atrial fibrillation does not cause any further symptoms in those patients. But we do have a scoring system that every doctor in the United States uses, and it decides who needs to be on a blood thinner. It's called the CHADS VAS scoring system. And no matter where you go in the country, they'll talk about what is your risk of stroke. And the higher that risk is, the more people benefit from being on a blood thinner. And I'm not talking aspirin. I'm talking a medication called warfarin, or many other, we have 3 or 4 other drugs that we now use that are similar to warfarin to protect those patients against strokes.
A lot of people have been taken off warfarin in the last few years and put on another kind of medication similar to warfarin, another blood thinner, but they don't have to go in for the testing as frequently. Yeah. Can you, either of you want to take that one on why I should have my mom take one or the other?
Generally, it comes down to cost. Warfarin's been around for a very long time. It's cheap, but you do have to go in for the blood tests. There are some people that it works wonderfully for. They are very well controlled. They don't mind going in for the tests. Their blood stays right where it should be, and it works. Other people, even though they try or they don't try, their blood does not stay in the nice range because warfarin does have to be adjusted. Foods affect it. Other things can make it get thinner or thicker, so it's touchy. And for some people, it just doesn't work. And if it's not working, if it's not staying in the range that it should be, if it's too low, you can get clots. If it's too high, you can bleed. And those people are much better off on the newer ones that are not nearly as touchy. The problem with the newer ones is they're new, they're brand name, there's no generic, and they're pricey. If you have to pay out of pocket, they are extremely pricey. And insurance companies cover them to various extents, and for some people, price is the make or break. If your insurances cover them, the newer ones actually have some good data on preventing strokes, and that's why you take them, preventing strokes just as well, if not better, and having less bleeding risk. I mean, hey, if you're going to pay the same out of pocket, why not? Easier to take, less monitoring, less risk of bleeding, same stroke protection, if not better. Go for the newer ones, unless it's going to cost you an arm or a leg.
Good, thank you. This is a family doctor question, I think. Someone wants to know, is there any significance to high calcium levels when a person gets their blood drawn?
Depends on how high, and there's multiple reasons to have high calcium levels. Some of them can be some other drugs you're taking, hormone imbalance, all the way down to cancer. So yes, possibly, and certainly depending on the calcium level.
Lots of it depends questions tonight. Dr. Erhard, just a clarification, you had said that you had a test done every 5 years on yourself. Can you remind the audience?
Yeah, that's called a
is?
CAC, or a coronary artery calcium score.
Okay.
It's a CAT scan that is now offered by most hospitals in the United States. It is offered at a price that is less than the cost of doing the test as a service to the community. And that test in the state of Minnesota is now between $100 and $200, and it's a once every 5 year test that can really help guide your care and your cholesterol and reassure many patients. So I find it very therapeutic for people that have early family history. CAC, coronary artery calcium score.
Thank you for that. I think we have time for at least one more question. What is left anterior fascicular block? And is there a treatment for it?
Yes, there is a treatment for it. You ignore it. This heart, if I could show it here, has a bottom chamber called the left ventricle. And at the top of the heart, when the sinus node, which is our body's pacemaker, communicates to the bottom and tells the bottom to squeeze, it has 3 pathways to get the impulse to the bottom part of the heart. Man has not designed a pacemaker as good as the heart comes with. And the left anterior fascicle is part of those 3 pathways. Is the right bundle, the left bundle, which is made up of the anterior and posterior fascicles. And having one fascicle out means nothing negative for anybody at all. So it's not a problem with their heart. If all 3 are out, you have no communication to the bottom, and those people need a pacemaker.
Okay. Dr. Heren, sorry, going to throw you one here. Last question. A patient had her left knee replaced, then went back in for heart failure and pneumonia, and now has to do breathing exercises. Why do you think that she got some of those, or what are some possible reasons that she might have gotten that from the knee replacement? Actually, either of you.
Well, knee surgery gets you in the hospital and makes you not move so well. If you're not moving so well, you often don't breathe as well, and that can set you up for getting pneumonia, which is why they have you do incentive spirometry, or at least try to. And I'm not sure how the heart failure can tie into that. One assumes some underlying heart disease. The pneumonia does not help, because if you have lung congestion, it makes harder for the heart to pump blood around and puts more strain on the heart. So that can be tied into the pneumonia. Yeah, it gets down to all parts of your body are related.
Well said. Anything to add to that, Dr. Erhard?
I thought that was well done. It doesn't take long for us to get out of shape.
Yeah.
And a knee injury, that's why one of the things with orthopedics, we get them up very quickly after and get them moving. And that's what we want to do.
All right. One last question on HDL and LDL ratio. Is there any benefit to, how should that look?
Well, if you're blessed and your HDL and LDL are the same, you almost never get heart disease. And most people that have coronary disease are 3-to-1 bad cholesterol or 4-to-1 ratio.
Or 5-to-1. I've
Or
seen
worse.
6-to-1.
Yeah, or 10-to-1.
There you go.
Any last words as we tie up?
I think from my aspect, go to the things you can change, which is exercise, eating right, sleeping right, and doing our best to avoid the toxins that we have around us.
I want to thank our panelists, Dr. Mark Erhard and Dr. Victoria Heren, and our WDSC phone staff. This is our last program of the season, and thanks to all the doctors and phone volunteers who have been with us throughout the season of Doctors on Call. We hope you've enjoyed the program. Thank you for watching, and good night.